Hi everyone, our subject today is joint pain in pediatrics. Basics. Arthralgia is joint pain with or without physical finding. Arthritis is joint swelling or presence of two or more of the following: joint pain with motion, decreased range of motion, or warmth or erythema overlying a joint. The degree of joint pain and diminished function accompanying arthritis is variable. Knee pain we'll discuss in another lecture. History. Although arthritis typically present with pain and physical findings, occasionally joint finding, swelling, redness, warmth occur without any associated pain or restricted motion. In neonate, clinical manifestations of arthritis are non-specific: poor feeding, irritability, pseudoparalysis of an extremities. In children, morning stiffness or stiffness after prolonged period of inactivity are common. They may also experience referred pain. Hip disease may be referred to the knees, and pelvic pain may be referred to the back, hip, or anterior thigh. Arthritis may also present as limb. The history should include the detailed description of joint symptoms, include the affected joint, duration, severity, and pattern of symptoms. Recent illness, travel, trauma, immunization, and medication are also key history elements. A thorough review of system is important because rheumatic disorder can affect virtually all organ system. Inquire specifically about weight loss, anorexia, and fever, as well as history of sexual activity. Assess the impact of a complaint on sleep and usual activity. Bone pain severe enough to cause nighttime awakening, especially in associated with more constitutional symptoms like fever, weight loss, should raise suspicion for possible malignancy. Physical examination. Generalized physical exam should be assessed for sign of acute infection. Overall growth parameter, ocular finding like uveitis, lymphadenopathy, hepatosplenomegaly, and cutaneous finding could all yield clues to the possible diagnosis. The physical examination should include observation of the gait, comprehensive joint exam, and focus exam on each affected joint, ideally using contralateral side if unaffected for comparison. Careful discriminant between extra-articular and intra-articular swelling must be made. Adjacent extremity should be assessed for bony tenderness and muscle atrophy. How to approach to child with arthritis or arthralgia. Perform history and physical examination. If it is monoarticular, which is one joint affected, concern for septic joint, acute onset, rapid progressive, fever, joint warmth, erythema. If it is no, this is a transient synovitis. If it is yes, the patient needs CBC with differential, ESR, C-reactive protein, blood culture, test for gonorrhea, imaging, X-ray, ultrasound, consult orthopedic radiologist for joint aspiration. If it is abnormal result, differential diagnosis, septic arthritis, including Neisseria gonorrhea, leukemia, tumor, hemoerythrosis, trauma, coagulopathy like hemophilia. If it is normal or inconclusive, as patient if has oligoarthritis less than 4 joint. If patient has polyarticular, we will discuss it in detail soon. Please see previous lecture of heart murmur for Jones criteria. If patient has oligoarticular less than 4 joint or non-migratory polyarticular, review clinical characteristic associated with sign and symptom. If patient has history of exposure to endemic Lyme region, supportive clinical characteristic, patient need ELISA. If positive, patient need confirmatory test with the Western blot, differential diagnosis, Lyme disease. If there is associated back pain, spine or sacroiliac joint, enthesitis, morning stiffness, loss of lumbosacral flexion, family history of disease associated with the HLA-B27, patient need HLA-B27 and ANA. Differential diagnosis: enthesitis-related arthritis, juvenile ankylosing spondylitis, inflammatory bowel disease. If patient has psoriasis, dactylitis, distal interphalangeal joint involvement, nail biting, onycholysis, family history of psoriasis, also patient need HLA-B27 and NAA. Differential diagnosis: psoriatic arthritis. If patient has gastrointestinal symptom or genitourinary symptoms, patient need culture for gonorrhea, chlamydia, stool culture, HLA test. Differential diagnosis: reactive arthritis, disseminated gonococcal disease, and inflammatory bowel disease. If the patient has skin finding, differential diagnosis: vasculitis syndrome, serum sickness, Lyme disease, dermatomyositis, Behçet syndrome, viral associated arthritis like after infection with parvovirus, rubella, and enterovirus. If patient has lower extremity arthritis, knee, ankle, morning stiffness, easy fatigability, poor sleep, absence of psoriasis, and spondyloarthritis, onset before 16 years of age, and duration more than 6 weeks, the patient need complete blood count with differential, rheumatic factor, and NAA. Differential diagnosis: juvenile idiopathic arthritis, oligoarticular or polyarticular according to the joint involved. Continue. If patient has a history of daily fever more than 2 weeks, transient migratory rash with fever, hepatosplenomegaly, lymphadenopathy, serositis, or pericarditis, patient need complete blood count with differential, rheumatic factor, NAA, and ferritin. Differential diagnosis: systemic onset juvenile idiopathic arthritis. If patient has associated with the preceding infection, as we mentioned, parvovirus B19, rubella immunization, post-streptococcal, mumps, enterovirus, hepatitis B, HIV, cytomegalovirus, and varicella. If patient has other non-specific finding or generalized symptom, differential diagnosis: SLE and leukemia or other undifferentiated arthritis. If the patient has polyarthritis, polyarthralgia, is the sign or symptom present for less than 6 weeks, patient if onset in hours, keep in mind septic arthritis, traumatic, or coagulopathy. If the onset in days or weeks, differential diagnosis: viral, reactive, leukemia, acute rheumatic fever, Kawasaki disease, and maybe beginning of the JIA. If the sign of inflammation present for more than 6 weeks, if the patient has extra articular manifestation, either infective or non-infective, infective, acute rheumatic fever, and TB. If it is not infective, differential diagnosis: SLE, inflammatory bowel disease, juvenile dermatomyositis, Kawasaki disease, systemic onset JIA, psoriasis, and maybe malignancy. If the patient has only articular manifestation, the differential diagnosis: post-streptococcal rheumatoid arthritis, SLE, JIA, and psoriasis. If the patient have a specific joint involvement, like temporomandibular joint involvement, this is JIA. If patient has dactylitis, distal interphalangeal joint, this is psoriasis. If there is a skeleton tomography, if it is axial, this is juvenile ankylosing spondylitis. If it is peripheral with symmetric, this is SLE or JIA. If it is peripheral and asymmetric, this is reactive. Clinical finding of fever and refusal to bear weight are more predictive for a septic joint than non-bacterial etiology, as are an increase in C-reactive protein, ESR, and white PC. The more of these findings are present, the greater the risk for septic joint. An acutely inflamed single joint needs to be aspirated if there is any concern about a potential bacterial infection, as we mentioned, septic joint. The most common agent of septic arthritis in children and adolescents are Staph aureus, group A Streptococcus, and Streptococcus pneumoniae. Kingella kingi is beginning increasingly recognized as an etiology, particularly in children under 4 to 5 years of age. Salmonella, important cause in patients with the sickle cell disease, but keep in mind that Staph aureus is still the most common cause of infection septic arthritis in patients with sickle. Just Salmonella is more recognized in patients with the sickle cell disease. Neisseria meningitis and Pseudomonas aeruginosa, as if the patient has a puncture wound by a tennis shoe. Group B Streptococcus and gram-negative enteric rod can be causative in neonate. Arthralgia and arthritis in knee and hands may develop 10 to 28 days after immunization with rubella vaccine. This reaction occurs most commonly in post-pubertal females, and associated rash may occur. Post-streptococcal arthritis is an oligoarticular, non-migratory arthritis that affects mostly lower joints after infection with group A Streptococcus. These cases do not fulfill the criteria of Jones criteria for acute rheumatic fever. Controversy exists over whether post-streptococcal arthritis is a distinct entity or an incomplete form of acute rheumatic fever. In children, systemic lupus erythematosus most commonly present with non-specific symptoms. Malaise, fatigue, small joint arthralgia, and arthritis are frequently present but overlooked in early phases of the disease. Adults classically experience a migratory arthritis. Hepatitis B arthritis dermatitis syndrome clinically mimics serum sickness with an urticarial rash and symmetric migratory polyarthritis. Top tips of arthralgia. Every attempt should be made to ensure that there are no signs of arthritis, red, hot, and swollen joint, and to localize the arthralgia. Once a joint is found responsible, diagnosis becomes easy. Arthralgia of the hip include transient synovitis, Perthes disease, or slipped capital femoral epiphysis. The slipped capital femoral epiphysis typically affect obese, short children, and those with the rapid growth spurt. Painful ankle may be due to sport injury, the most common cause, or referred pain from avascular necrosis of the navicular bone, cochlear disease, or metatarsal head, Freiberger's disease. Although persistent arthralgia without evidence of arthritis is uncommon in JIA, arthralgia lasting several weeks may occur in pre-arthritic stage of the disease. Red flag of arthralgia. Arthralgia due to malignancy is typically disproportionately constant and severe compared to the clinical finding. Full blood count may reveal low hemoglobin and platelet and diagnostic peripheral blood smear for leukemia. Early diagnosis of leukemia is important. The use of the steroid and immunosuppressant without excluding hematological malignancy is likely to mask and delay the diagnosis. Remember that the diagnosis of JIA should only be made if there is evidence of arthritis, not arthralgia, persistent for more than 6 weeks, and if other diagnosis has been excluded. Top tips of arthritis. When a child presents with arthritis, the first question is as follows. Is it monoarthritis, oligoarthritis, or polyarthritis? That alone can restrict the differential diagnosis. Transient synovitis is diagnosed by mild or no fever, history of viral upper respiratory tract infection, and one hip being affected. Child appear well, limping, but still walking. White BC, C-reactive protein, ASR are usually normal. White BC count in the joint fluid is less than 50,000 cell per millimeter. It is self-limiting, usually lasting 1 to 3 weeks. Systemic onset JIA can be diagnosed by an intermittent high fever, often hectic, with a daily rise in the evening, then falling to the normal in the morning. The pattern may become double quotidian. Fever is often associated with the occurrence of rash, lymphadenopathy, and splenomegaly. Septic arthritis, usually monoarthritis, is characterized by high fever, more than 39.5 Celsius, severe pain, restricted range of joint movement, and refusal to walk. It is defined as positive joint fluid culture for bacteria and or white BC count in the joint fluid more than 50,000 cell per millimeter, mainly polymorphous nuclear cell. Rheumatoid factor is characterized by migratory arthritis occurring 2 to 3 weeks following an untreated group A beta hemolytic streptococcal pharyngitis. Diagnosis is established by Jones criteria. ANA are specific for nuclear constituents. These are important arthritis tests. They are positive in nearly 100% in mixed connective tissue disease, in over 95% in SLE, and about 50% in JIA. Red flag of arthritis. Uveitis may be the initial presentation of JIA, particularly with oligoarthritis. 1/3 of children will develop unilateral, even bilateral loss of visual acuity. Regular eye check are essential. Neoplastic arthritis should always be borne in the mind. Diagnostic clues include the presence of lymphadenopathy, hepatosplenomegaly, anemia, thrombocytopenia, or blast cell on the peripheral blood smear. Pyrexia is usually mild or absent. Bone marrow aspiration is diagnostic. Temporomandibular arthritis in JIA is challenging to evaluate because the absence of joint swelling. If untreated early, devastating effects occur in its form and function. In TB arthritis, there is typically a lack of response to treatment with antibiotics, non-steroidal anti-inflammatory drugs, or intra-articular steroid. Diagnosis is made by positive Mantoux test with possible TB lesion in chest X-ray and synovial biopsy. Thank you for your listening.